tassm International Conference of Aesthetic Surgery and Medicine. And now I'll lead the floor to Cathay General Hospital and keep our online streaming. Thank you, everyone.
I will introduce Dr. Li Guanyi. Dr. Li is the Chief Director of My Best Cosmetic Plastic Surgery Clinic. He graduated from National Defense Medical Center, and he now is an active member of many institutions and society. He is a member of Taiwan Society of Plastic Surgery, and he is also an experienced and senior plastic surgeon. And he is also a member of Taiwan Society of Surgery and the Taiwan Cleft Palate Craniofacial Association, and Taiwan Academy of Facial Plastic and Reconstructive Surgery, and Hyperbaric and Undersea Medicine of Republic of China. And he is a very experienced plastic surgeon, and he will present us a forehead endoscopic lift. And let's start. Okay. Thank you.
Thank you, Dr. Pu. Introduction. Hi, everyone. Good morning. It's my honor to be here to demonstrate the operation. Today, the operation will be endoscope assist forehead lift or brow lift. I will present today's the patient's conditions. This 50 female complain he have drooping eyelid and the puffy eyelid and asymmetry of the brow. The patient had the problem for a long time, especially these 4 years. So today, the patient come to me for the problem. And after I assess the condition, I suggest the patient have better procedure is to lift the brow to correct the ptosis. So today, I use endoscope assisted endoscope lift. Next slide, please. Under endoscope, I try to subperostin dissection plan and totally dissect include temporal area, forehead area, and finally I'll fix the forehead flap with endotype device to get a more rigid fixation. And today, the patient here, she has also complained the eye bag, but today the eye bags will be not present today. And okay, let's go begin our procedure. Thank you. First, I have 4 incisions behind the hairline, include 2 temporal incisions and 2 perimedian incisions forehead here. local 30G 的针头，先给我 local。
Dr. Li,
Yes.
Can you explain what kind of local anesthesia do you use?
I use 2% cytokine for the incision wound injection and the nerve block of supratrochlear and supraorbital. And then I use tumescent over the forehead area to reduce the bleed and ecchymosis after the operation. The temporal incision usually was designed behind the hairline about 2 to 3 centimeters, just the line, area, little cancer area, the line just there, and 2 to 3 centimeters behind the hairline. Before I injection the cytokine, I check the position here. avoid the injection to the artery. OK， 有30G 的针头吗
30G 的，要30G 的哈。
对。
下部，下部可以了。下部。
下部呀，先好。And the midline of the forehead, I have 2 incisions, paramedian about 3 centimeters, and behind the hairline about 1 to 0.5 centimeters here.30G 的针头再给我，换30G 的针头。These patients have the asymmetric brow. Since she was young, sometimes we will find the skeletal orbit was different level. So sometimes we can find asymmetric brow. So we have to explain to the patient that sometimes we have correct the brow ptosis, but it could be asymmetry. It could be asymmetry even after the operation. I try to block the nerve.
Can you explain the landmark of the nerve?
Yes. We can try to feel from a notch here and the supraorbital here, or the pupil level or mid-pupil level. So we can have about 0.3 to 0.5 cc stroking to block nerve. We can feel the notch of the supratrochlear. Okay. Also, I have the zygomatic here over the zygomatic temporal nerve. Sometimes zygomatic facial nerve block also. You can feel the notch here. Here, zygomatic facial foramen. OK， 笔再给我一下，没关系。Sometimes we could palpate the zygomatic arch and mark to define the dissection area. I mark the upper border of the zygomatic arch, and the dissection lower limit will be there. OK， 好，那个 tumors 30。Okay, I use the tumescent solution.
Do you inject deep into the deep just above the periosteum?
Yeah, just periosteum. Yes. We need to protect with the finger to make sure not to into the optic cavity. Yeah, so, after tumor cell injection, that can keep clear operative field clean. And to the zygomatic, upper zygomatic body, I will dissect here.再给我一个，完了，听不见。好。Almost done. Okay. Right side first. 可以给我椅子吗？哎，谢谢。他刚。好。15号，对。那个 potato 有没有 ？potato 有泡消了没？有吗？下去。待会去。来，笨姐 ，kiss，是纱布来，波斯明纱布。波斯明纱布。给我。我不这个。baby， 缺的。baby 缺说你好了，我这工作同正过。
So Dr. Lee,
Yes.
here you will approach to direct to the deep temporal fascia.
Yes, the plan of the temporal area will be supra deep temporal fascia.
Yes.
And I go into the area, a vascular area plan. It's a set plan to prevent injury the nerve of frontal temporal branch. Initially, we get adequate walking distance here. Back potato. 是啥？是啥？等一下要小的哈。来 potato， 大的，对，大孔的 ，baby 来 ，mosquito 来，两个 baby 把伤口打开。OK， 提一下。I use the protector to protect the hair follicle of the incision to prevent, as possible, the surgical alopecia. So we try to protect the incision as we can. 提上来。等一下。出来。
Okay. This is a good device to protect the hair follicle.
It's helpful.
Yeah.
Elevator 准备了，然后光源那个都接好了哈。快 balance 一下哈。Elevator 我的机械消好了哈，打开，然后要点一下哈。Usually I use about the dissector for the endoscope. Different shape, different curve. 宽头的 dissector， 宽头，平的，方头的，对。Yes 啊。Okay. Scope 准备哈。First, I use the square tips of the dissection elevator to get more far working distance. We can feel the forehead, the bone, and go deep to the subperostin plan layer. Always keep the plan just above the deep temporal fascia. 好，来 scope 来 ，shift， 对，套上来。那等一下啊。来 suction 全在这里，来线过来一点。线是过来。对，
这次往前。
好，我的 dissector， 我的 dissector， 刚刚那 elevation， 我的 dissector。没有东西。镜子没有摔到吧？镜子，对。感觉这镜子怪怪的，对啊。太吵了。镜子没有摔到是这样子。好。这样子。对。它卡到了是吗？哦，好，对了，对 ，lock。都卡出来。 好。头帮我扶一下哈，稍微转过去一点点啊。We just go ahead. We release temporal adhesion here and go into the bone area of the forehead. Okay, we can find the sentinel vein.
Yes, here is the sentinel vein.
对，
The landmark
尖的
to avoid the facial nerve. You have to
尖的那个不是尖头的，
watch out the facial nerve
最尖
here.
的这一把。对
Do you
And,
coagulate this? Or
I
not?
changed to use the 5 tips elevator to protect the nerve and the vein.
Dr. Lee,
Yeah.
do you coagulate this vessel or not? Or just leave it alone?
It could be sacrificed, but I don't. I try to keep that as possible because when I sacrifice the vein, maybe ecchymosis around the periorbital area. So I try to keep the vessel intact, not to damage that.
Yes.
But sometimes I augmentation to put the implant here. I have to sacrifice the nerve and vessel.
Yes.
But today I just to elevate the brow, so I will keep that intact. Try not to injury or damage.
Okay.
Go behind the vessel. Yeah. Okay, we just approach the area of lateral brow here. Very dense ligament. We need to cut or need to coagulate to lysis. 电烧，长头电烧。我有一个长头的电烧，换一下。来，帮我拿着。Small veins around here we can to coagulate. The small vessel here to prevent bleeding. 现在电烧是多少？15的。好，可以，这样可以。suction 可能要稍微大一点。把弯的那一把来，弯的 curve， 弯的隔壁那一把，对。电烧，等一下跟我稍微suction稍微强一点，对。And gradually we approach central flat.
So Dr. Lee,
来，电烧。
Dr. Lee,
Yes.
Now you are going to release the temporal fusion line.
Yes, I already released the fusion line here and go subperiosteally. I just released the ligament here. It's quite strong, so adequate release is needed to get a better result.
Yes, I think the supraorbital ligament is very important. You have to release it to elevate the brow.
Yes, adequate release. 先的那一把给我。是的。Zygomatic temporal nerve, yeah. We keep that also. 厮杀给我来一个小块的，有没有 ？Boss me， 就这么小块？啊，那个，长的镊子夹给我，有没有镊子？ENT 常用的那个。Sometimes I will use the compression here to keep that bleeding stop. 来，纱布干的来。干纱。弯的那一把来 set。Okay, we can go ahead to superior dissection safely, just about 2 centimeters about the eyebrow here in brown fashion. Okay. 纱布再来一块好了，小块的。 快纱布了。During the compression, we'll go the next incision. Our medial incision, just behind the hairline, about 0.5 centimeter to 1 centimeter. 来，倒来。好，换的那一把再给我。Elevator 换的那一把。Adequate release of peroxide. 好，来 potato 小的。Baby mosquito.
Dr. Lee,
Yes.
the incision in paramedian, you will direct to the peroxide.
Yeah, cut to the peroxide. We also go subperoxide. 来，另外一把。Plan 2 slices. 那个有没有小的 elevate？ 这个 baby 小一点，干嘛？稍微提一下，对，这它太长，这太长，也有小的哈。提上哦。好，有没有小的？啊 ，OK， 出来，先等一下。Smaller one。OK， 好。勾进去一点，一定要勾进去，然后稍微提一下，不用扒很开，提就好了。对，把头发拨一拨。We also use the protector for the incision. 好，出来。好 ，scope 来。好，长捏，我把。来。scope 对。好，顺一下。好。来 ，scope 夹子 ，scope 的夹子，给我。黑色的夹子，不是剪刀，对。换的那一把。OK。Continue approach to the supraorbital area. 有一个 suction tube 抽痰管，抽痰管，对，软管。介绍学有。收着就好了。好。要选比较弱。好，弯的那一把再给我一下。对，这最好这样看起来。头帮我 hold 一下。来出来一点，一点点就好了。对，它比较弱，要出来。We need to release the peristaltic just above the supraorbital area, and we should be careful. We can find the supraorbital neurovascular bundle layer. 来，剪刀给我。剪刀 ，Scope 的剪刀，黑色的。哎，不对，那一把先给我，这把跟那个都在一起 ，hand piece。介绍给我一下。我们解麻醉科加一支全沙木。全沙木。剪刀给我吗？We try to lysis the peristaltic.弯的那一把吗？弯的那一把。大弯的那一把，另外一把大弯的器械，对，不是，对吧？ 版本那个档就觉得好。Continue the session. The same plan to get a better area or walking distance. Abu 再给我一下。对，刚刚用闪的。我的黑色的夹子给我。对 ，OK。我这边拿出来，先 compression。这是 both me。Both me。Yeah, compression. The area we just dissect. Because neurovascular here is quite easy to bleed, quite easy to bleed. So we sometimes need to compression.
And Dr. Lee also used tranexamic acid. The brand name is tranexamine to reduce the.
I always use like epinephrine.
Oh.
And sometimes a little bit cannot cut. Okay, incision. Okay, we can find the temporal fascia. So that's right plan we need to dissect. Protect. Mosquito 了？不是，你没有勾进去。No。勾进去，然后要稍微提一点点。你没有一个 space， 我是放不进去的。提上来一点点。是哪问题啊？拿出来。好，出来。OK。翻头，对。Just about the deep temporal fascia dissection. All right, let's go. 我可以站起来吗？可以哦。Okay, the temporal adhesion here, and they go deep to subperostin to create a pocket.
Can you open the temporal fusion line already?
Yes. We go through the line. right side have much more waiting time, so bloodless. It's all good. And I think it will. Inferior temporal Saturn. If we try to some case for the total face, maybe you can go deep to the deep temporal fascia superficial layer and to touch the bone of the zygomatic arch, then dissect. Keep the nerve upper side safely. But today we just correct the brow, so I don't go through the superiority into the arch.
And we can go through mid face to
Yeah.
this area, right?
Yes. Because right eye is bleeding, so I stop to go to the mid facial area, and maybe later I can go into the mid face subperosity of zygomatic body, and then dissect to create a larger dissection, a better result of elevation. That's all. Suction 可以大一点。suction 现在是最大的吗？最大了，好。OK。好，翻着那一版给我。Different curve, different angle, different elevator. This 介绍再给我一下。来，那个尖头的那一把，这个电烧比较，我们接那个suction tube。尖头的给我，镜头擦一下。 Okay, we can find a centennial vein. Keep that.发布了，先量一下哈。纱布不是纱，嫁给我。出来，鼻子很高，一点，往回流。OK, compression. 来。刚来。嗯。换的 elevator 来，换的那一把。嗯。Potato 来 ，mosquito 来 ，baby 来 ，baby， 不是。好来，出来。顺一顺再拿给我，换的那一把给我，来上来一把。好，测一遍，帮我转一下。Yes。啊，手收好啊。Continue to dissect subperiosteum till the supraorbital area, and then release periosteum. Sometimes we do the myotomy of the depressed muscle, but I usually use in the male patient because of strong muscle. But for the female, I don't do that.
And do you cut all of the provocator or procerus muscle or not?
For the male patient, I just my otomy.
Otomy.
Release, not just ectomy. Okay. Release the periosteum here.剪刀，这个suction好像都比较不是那么的。剪刀给我一下哈。Okay. We try not to insult the neurovascular to protect that. 这个 suction 还是有时候会太弱一点。从这里啊，从这个洞。不行，还是不行。好，好，出来没关系，那你就放在这里。好，不是放在接到这里来了。好板站 ，scope 擦一下哈。夹子给我一下，黑色的夹子。好了哈，好，给我。大湾来，来抽个水好了。给我碗水。全上面打了吗？水给我一管。
全上面给他打了吗？
啊，可以，可以。
全上面打了。好。
啊，剪刀给我哈。大弯好，大弯那一把。对。Glabella dissection. I use bilateral paramedian inlet. Just dissect. Don't use the scissor. It's quite dangerous here because there also a neurovascular bundle here, chocolate. So just blunt dissection, subperiosteal invasion.
Dr. Lee, can you show us the muscle, the provocator, procerus?
OK. 好，剪刀给我一下。
剪刀。
Meanwhile, we first can see the procerus muscle here. But sometimes the patient, if have the Botox injection here, the muscle was so tiny, become so tiny and thin. Slowly dissect and release the peroxidine.上水没有接，上水。来刷一下，bench 那里洗手。啊，给我。换的那一把给我，换的。嗯。Okay, we can see the muscle fiber here.
Yes. It's not strong. It's
it's thin. It's thin, especially in female patient have the Botox injection. We should not over dissection because the tissue is thin here. Okay, we almost release the peroxidine. Okay. gap between the supraorbital to the end of the peroxide about 2 centimeter. 1 to 2 centimeter. It's enough. Okay. You cannot clearly identify every muscle here.
Yes.
It's so thin and a little bit translucent, so I don't continue to dissect here. Okay. Next step, we will dissect to the mid face.好，来头帮我固定一下，来顺一下。圆头的，死的圆头的，对。
要可以，也都要知道意思。
不是 ，That's the demo.
Okay, let's continue to dissect after the bleeding is stopped. I go to the mid face in between the nerve and the vessel. And when you go approach to the bone area, we go deep as possible. And we can touch the bone. And then subperostin dissection go downward.
It's zygomatic body.
Yeah, go downward. We can find the bone there. Okay. We now approach to the mid face from this incision and from this inlet. Okay. And now I can go without the scope down to the mid face. Mid-third of the arch is danger zone, so we do not approach to the mid-third area. Just first, medial third is enough. So almost I have dissect the bone of zygoma subperiosteally and get a more better result through the forehead and temporal area. Okay. Sometimes you can use long endotime, fix the malar, and the lift also. Combine two procedure.
李院长，
Yes. 哎，
谢谢辛苦的示范 ，Thank you for demonstration。我问个问题，就是说，那你在播的时候，你会播到那个特别播到那个 prezygomatic space 吗？去lifting 那个 mid face 躯壳的地方？
它的范围还是有限，
是有限的，
没有办法 totally， 因为角度的关系，
是，
而且外侧我们尽可能要小心这个 mid-third 的这个 zygoma arch 的地方，所以能够走的范围并不大，但是远可以走远，但是宽度的话大概比较受限，会比较受限这个 distance。
我看这个方法是很好，因为刚好可以做 mid face lift， 再做那些那个 endotime 的 lifting 是这个从这个地方进去做嘛，哈。
对，
我看的效果应该比较好。就你都会combine跟 endoscope 一块做吗？都会跟combine跟那个前额拉一块弄这一块是吧？
patient 如果有需要 前额拉跟 mid facial 我有做过2套的 endotype mid face endotype 跟 forehead。好，我们 check 一下哦，有没有 adequate relief 来那个尖头的。
I just asking the Dr. Lee to dissect down to the mid face to the cheek to get more favorable results for the patients. So the patient's satisfied rate will higher. Because sometimes we lifting the forehead, the patient feel rejuvenation of the upper 1/3, but sometimes they will notice that the mid and low face is still aging. So we have to talk to our patient to inform them that we focus on your upper 1/3. So maybe you will feel the mid and low face still aging after forehead lifting. So it's very important to inform your patient beforehand.
这个没有粗一点的哈，要学 tube。
要再粗一点的。
有吗？
有啊，那软管再粗一点。如果你这个更粗一点，它就太软。这个再进去的更粗一点。
好，那个纱布再来压一下，因为今天这个培训比较流血哈。来，夹子黑色夹子给我。那今天我们有拨到中脸部，所以也会比较肿一点啊。好 ，OK， 等一下，先进去，行。
另外一个小问题就是说，这个它的incision opening 的 protector 是 MIT 还是 MI 在哪边制造？这个细胶的保护器？
尖的，尖头的。好，对，好。我会保护这个血管哈，因为避免眼周，因为血管断了会缩进去，那个 bleeding 不好 check， 所以我都会保留。如果不是做 augmentation of temporal 的话，我都会保留。那要做 augmentation 就必须 sacrifice 哈，就是会把它烧断哈，但是可能就是会淤青的感觉会比较深层。OK， 这边的，来圆头的那一把给我，来擦一下圆头的，圆头的，
镜头擦进去，
镜头，好，圆头的，那是方头的，圆头加了。好 ，OK， 一样好。In between and the vessel, I go to the mid face, touch to the bone, and go deep as possible to the subperostin plane. OK， we touch the bone and go subperostally, then go. OK. That's that. Also, we need to sacrifice like a multifacial neurovascular bundle there in order to have a better dissection, subperostin of lymphoma to the mid face, and go laterally. Okay. Okay. The area is about the metal area. so we have a better lifting effect. 啊，纱布来塞一些。小纱布，嗯。啊。再来。再来一个。那是按你那个Sesi II来，哎，tube来，有没有粗一点的？Compression for a minute. Some people mention that totally release the glabellar muscle can have a longer result of the forehead lift, but you have to describe the expression of the patient. Only one expression. 来，上水，来，那冲水来。啊，弯的那一把，弯的那一把，对，对。再来。等一下。I don't like use the strength after surgery. So after surgery, I use the elastic bandage of the forehead 2 days.
And any medication should we give after the operation to prevent the ecchymosis or hematoma?
I use the tassm. Yeah. Take home. And of course, compression is important. So I use a elastic bandage 2 days.
2 days.
Over the forehead area. 来，水来，冲水一下。
And 2 days later, the patient come to your clinic to remove that bandage. Or
the patient can remove the bandage by herself at home.
Okay.
Yeah, it's quite easy. So my patient always release bandage by herself at home. 再来，放一下水。好。好，我们换边了哈。我掌控了。scoop 来。scoop。擦一下，来。来，看。 冲水哈。关的那一把给我。再来。再来。Okay, we are going to set the endotyne device. So we need to drill a bone permedially.
Endotyne.
来，那个钻头，是干砂给我。
像那个砖。
再一块，再一块。帮我一人压一边。白高麻这边稍微压迫一下。它那个钻，它的那个器械。
那个消毒的。
转轮的。它那个有一个是胡椒粉，还有一个是转轮。转轮的。suction tube 放在哪里？不在哪？不要拿出来，不要走，让它在这里。在两面。压着。到太阳穴都压着哦。Okay, we can try to check the flat. Can be moved easily, downward, upward. 你会装吗？把那个去啊，刀上去。哎，它有个 key。
两只都可以吗？
对，两只都可以。它一只 UV 怕你掉在地上。好，再麻烦你小心一下。可以拿过去。OK。把头发帮我那个，它会卷下来啊。头扶好哦，我开始要钻哦。来，那个镊子给我一下，不是 ，tiss。对，把这个给我，我要 check 一下深度。头扶好哦。比较锈掉了在。好，来镊子再给我一下。水给我冲一口。
水，冲水。
OK, next。分别来。好，你先放手，手放手，然后对的位置，头发拨一下就好，把它头 hold 稳。Dr. Gao, you can share your experience
Dr. Gao, are you there?
Yes.
Yes. Can you share your experience about the?
I think the endotyne, the forehead set is good for lifting for a periostin readhesion. But at my beginning learning, I just used driller to use the driller bit to make a tunnel, and I used the 3O vacuum or 2O vacuum to suspension the forehead to the tunnel, so we can save a lot of money to pay for the endotyne because endotyne is quite expensive. So, but just depends on the patient. So if you want to shorten the surgical time, I prefer to just use endotyne. It's easier for surgeon to finish the surgery. Regarding the breathing, sometimes I prefer use the tissue glue. So we can choose draining tube or use the use the fibrin glue. But some surgeons they didn't use the drainage tube or fibrin glue either. So depends the surgeon's habit. So how about Dr. Lee? Would you put any drainage tube or you use the fibrin glue to help hemostasis?
Yes.
你用引流管吗？还是会用一些组织胶来
？I don't use the drain because my patient always go home, don't stay overnight. So sometimes I use the tissue glue, especially when I augment the forehead with implant. I use the tissue glue to fix also.
那我用那个 endotyne 跟组织胶，我觉得好是可以减少肿胀跟出血。So I always combine the endotyne and the fibrin glue to help the recovery stage. But just
quite helpful.
Yeah,
yes.
Quite helpful. Yes, I agree totally. And sometimes I use the HBO hyperbaric oxygen therapy. HBO sometimes is helpful for minimize the oozing and help the recovery. 现在那个高压氧事实上也是蛮好用的哈，所以我们有时候会让病人做几个高压氧的疗程，大概术后第2天、第3天做个3到5天的 HBO therapy. I found HBO therapy after surgery is useful for the recovery.
Yes. HBO is a good equipment for surgeon to reduce the downtime.
So I want to ask and welcome any comment or question from the online participant. Any doctor, any want to comment or ask the question, you can just type your question here.
We have two types of the endotyne device of the forehead, 3.0 and 3.5 millimeter of the each time's length. Today I use the 3 millimeter length for the patient because female have more thinner tissue. 我有血，一点，好吧，去，鸭子，这边鸭子 ，Hello， 来帮我压一下，好，来那个爪钩，双爪钩2把，你把它3个，好，你把它。
Several years ago, some surgeons they just use the titanium screw. They did the external fixation. I think it's still helpful sometimes. You can put a screw for 2 weeks, and you just lift up the forehead flap on the screw, and just keep it for 1 to 2 weeks. The key thing is to dissection, to adequate dissection over the supraorbital periostinum. So dissection is very important. If you can do adequate dissection, and then you can have a good lifting effect. And some surgeons they even didn't put any suspension device. Some surgeons they did. They don't put any. They didn't put any lifting device or fixation device. They just release the periostinum. But in Asian face, because Asian face, it's heavier compared to the Caucasian face because the soft tissue quality. So Asian face is soft tissue is thicker and heavy. So we need to have a good lifting device, like endotyne demonstrating here. You can see that it's not difficult to utilize the device, but you do need a good assistant. And Dr. Lee is very famous and very experienced plastic surgeon. He have done many facial lifting surgery.
他们厂商的器械有一点钝，所以没有钻得不够深。好，水再给我一点。
Just a question for Dr. Lee. How often you will adjust the endotyne at the early recovery stage if patient feel asymmetry blood or sometimes you can adjust? 我问题是问那个李院长，就是说会不会在手术后的几天啊，帮病人调整那个endotyne的那个固定位置，会吗？还是说没有发生过？
不满意它的高度还是高度是吗？
对，高度会。
其实，在肿胀的时候，它的高度其实还不是那么的精准，
对，是
到位哈。所以调整的时间我一定会超过2个礼拜。
OK， 我同意啊，我大概也是等1、2个月来调整，基本上等病人6到8周消肿之后，再来调整会比较精确。那当然。病患刚开始看到会觉得有点 surprise 的，有时候他照镜子会吓到，所以有时候我们希望病人大概手术完过1、2周再回来门诊，主要是怕病人会担心那个术后的效果。So maybe you can do a minimal adjustment of the endotyne fixation. So Dr. Lee and me recommend you can adjust the endotyne fixation after 1 or 2 months. Two kinds of time of endotyne you can choose 3.0 and 3.25. Some surgeons prefer 3.5, some surgeons prefer 3.0. I personally prefer 3.0 because sometimes 3.5 patient will notice that a little irritable after surgery.
If the patient tissue laxity is prominent, more surprise have a better result after the surgery about 1 month later, because the tissue have adjustment time. The tissue we have to live more than our expect, but sometimes the age tissue slide down more quickly. So sometimes we have to first the brow looks surprised. It's better. My suggestion is better look surprised in early stage. You need to explain to the patient. The tissue will adjust to a proper position, and don't be so panicked early stage.
Yes, I agree. It's a good comment. Patient may feel surprised and very worried about the result. So I agree. I will do a little bit over lifting, because the soft tissue will be destroyed and settled down a little bit. So I will do over correction, a little more lifting.
Okay. You can hear click sound, and the instrument in this type, then release. Okay. Because right side brow is lower than left side, so I need to have a higher level on purpose. So we check that right side is a little bit higher than left side, right? Because the skeleton is quite asymmetry. The orbit of the patient here have a smaller or lower orbit skeleton that made the patient have asymmetric brow. So after surgery, the condition will be the same, a little bit lower than the left side. So firstly, I have to explain to the patient before surgery. Asymmetry. Okay, we engage the device and the rigid fixation here. Sorry， 压一下。拆线的时候要小心哈，不能用拉的；缝线的时候也不要用拉的哈，这样的话可能会脱钩。所以说这一点有时候patient一开始很好，后面歘的一下很快掉下去，我们要想到这个我们在拆线的时候用力会不会脱钩的问题，这样子。
I think the symmetry always difficult in cosmetic surgery, even the symmetry of eyebrow. So I will discuss to my patient that the symmetry difficult. Like eyebrow asymmetry still can happen after surgery, because asymmetry is not only the brow problem. Sometimes it related to the forehead orbital skeleton.
Yes.
有个线上问题，我用中文讲，那等一下再请李院长英文回答。问到就是说，我们在拨那个眼眶的 地方为什么要剪掉骨膜？
眼眶。
Yeah. So one question is, when approaching the orbital, why should we cut the periosteum?
In order to release adequate of the periosteum rigid tissue, including ligament adhesion. So we have to release periosteum and have about 1 to 2 distance gap. Totally release. We can make sure totally release. So the periosteum, supraorbital periosteum release is needed. And the lateral orbital area also release the heart tissue.我们在泰的这个伤口的时候，那个尽量力量是水平，不要往上哦。很多时候，有时候往上一拉会脱钩，或是护士小姐在剪线的时候，她一用力，有可能脱钩，你不晓得。哦，
那个院长，你会用那个钉子吗 ？Stable。
这个 stable 哈。
钉子钉比较快，还是用线？我看用缝线。
对，没有错。但是培群会吓到，所以我就用黑色的线来缝。
哦，对。
对，因为好多反应都是他旁边的朋友被吓到了，哎呦，这样的手术他不敢来了，所以就是说尽量让他不要尴尬，用深色的线帮他缝在头发里面这样子。
我拆线是比较困难，比较痛苦。
拆线对，拆线就是说有时候把它留长一点。
对 ，yes。
留长一点比较好找好拆。拆线不要用拉的哦，尽量就是贴着剪。或者是有一个 instrument 压着头皮这样子，这个点很多时候没有被提及到，常常在早期会松掉。
Good point. So if you want to remove the stitches, is be careful. Gently. Sometimes you take out the stitches and leave the我个人我是比较讨厌拆这个线，所以我是用订书机订，就是我会跟病患讲，就是说这个是医疗级的订书针，不然他会以为说我怎么头皮上有订书针，吓都吓死。
那patient会不会问说，他洗脸是正常吗？
可以洗脸，用那个一般我都建议他用沙威龙啊去，沙威龙应该不是广告吧，就是用沙威龙可以去洗头发。
搓揉脸部是 OK 的吗？
我认为是 OK， 我不晓得李院长会不会
可以轻轻的洗，尽量就不要有力度的去搓揉这样子。因为我不知道中间有没有什么其他的事情发生哈，所以尽量使力的一个状态，尽量就轻一点。
And how much time will it get stable?
Get stable. 4 months.
4 months.
对 ，4 months. The forehead flap tack to the new position take about 4 months. And you can do anything what you want. 搓揉压捏就可以放心很多。
Okay, thank you. 剩下关伤口。
对。
Okay. The operation is almost done. So because we have run out of time, so let's wrap up the section. Dr. Gao.
Yes. So we skip the lunch break. Maybe we can
skip the lunch.
Okay. 好，我们可能休息一下下。
Go to the lunch break. Okay.
好，再来冲水一下，放进来。
很谢谢国泰那边的辛苦，我想做那设计是非常辛苦的哈。那谢谢，那都。
Thank you, everyone. Now we will have a short break, and we'll be back at 1 p.m.
In the era of facial attractiveness, we're reborn through beauty. Everyone craves youth, expanded horizons, and unrivaled life experiences. And Miracle Thread emboldens us to pursue everything we want. Baby Thread. Its delicate material brings you comfy fillings and proliferation, regaining infant-like skin. Rose Thread. The lightweight steel design can bring the perfect solution to sagging and aging skin caused by partial drooping. We can regain confidence like blooming roses, unique and beautiful. Phoenix Thread. Its powerful lifting effect improves sagging contours, bringing back youthful fullness and elasticity, like the rebirth of the phoenix. Miracle Thread not only gives us a youthful V-lift face, but also unparalleled courage. I'm a newborn baby. I'm a thorny rose. I'm a flaming phoenix. Miracle Line makes youth online. Miracle Thread.
Good day, everyone. Welcome back to 2022 Asia TAASM International Conference of Aesthetic Surgery and Medicine and TAASM Annual Meeting. For this session, our moderators will be the chairwoman, Dr. Sui Shi in Cathay General Hospital, and the chairman, Dr. Chen Chang Steve Gao, here with us in the conference center. Dr. Gao, you may have the floor.
Thank you. Welcome back. I hope you already have a great lunchtime. Now we continue to the afternoon section. The first surgery will be upper blepharoplasty. Will be demonstrated by Xuanjun Ling. Dr. Ling, she finished her residence and fellowship at National Taiwan University Hospital. Now he's working at Universal Eye Center at Taipei, and also adjunct attending physician at the National Taiwan University Hospital. So today, she will demonstrate upper blepharoplasty. Let's welcome Dr. Lee.
Hi everyone, my name is Lin Xuanjun. Today I'm demonstrating an revisional double eyelid surgery. During the surgery, we'll do the septum reconstruction and levator muscle advancement for everyone. Because the time of my surgery is too long, so I pre-record it last week and show you the some part of the surgery. Okay, now I'm doing a neural block. The small picture, the small picture over left upper shows the picture of the patient before operation. She has a sunken eyelid and both eye ptosis. We know for ptosis patient, there always accompany some symptoms like the eyebrow is higher, and there is sunken eyeball, and there might be multiple crease and ptosis and lid back at the same time. So as when I correct the levator muscle function, some symptoms accompanied with the ptosis can improve, like the sunken eyelid and the multiple crease. So today I'm going to show you this surgery. I'm doing the local anesthesia near the periorbital region. We need to be careful that when we do the anesthesia, we need to do it very shallow, so to prevent affecting the OM and the levator. As long as levator muscle is over anesthetized, there come to more ptosis, and we cannot judge the symmetry during surgery. And if OM is over anesthetized, there comes to lack of thalamus, and the eye will bigger and bigger because it cannot close it as usual. So we cannot judge the symmetry as well. So we have to do the anesthesia at a very shallow level. Just beneath the subcutaneous is the best. Now I'm going to excise the skin. If we have time, wait for the epinephrine to shrink the vessel is the best way because it can reduce the bleeding. Maybe we can wait for the 5 minutes. Now I only excise the skin and preserve all the OM. This is very important because we can see she has the sunken eye before operation, and we want to keep the volume. So only the skin is removed. We remove only the redundant skin, but keep all the OM to maybe we will invert it later. So keep the OM without excise them. After removing the skin, we are going to make the incision line on OM. We should judge before operation that what's the problem of the eyelid. If the patient has a sunken eyelid, the incision side of OM should be lower. But if there was pretarsal OM removal too much in the previous surgery, so we can make a higher one and invert the OM down to the lower lap to add the volume of pretarsal OM. In this case, it's clearly that the volume of the upper flap is not enough, so I will make the incision of OM at the lower side. Okay, what I'm doing is irrigation by normosaline because I found she has redness on the conjunctiva. So I'm afraid that the discomfort of the eyeball will make her cannot open widely or like the natural, the normal feeling. So I irrigation for the irrigation by the normosaline to wash her eyes, because maybe there was some detergent in that make her conjunctiva in congestion. So now I'm doing a incision on OM and directly cut them until I reach the levator. Levator is a very special tissue that we won't miss it because it's white and smooth tissue. Like now we are going to see that. This is the levator aponeurosis. And why I choose the temporal side to be the first site to excise. Because this is a revision surgery, and sometimes there's too much adhesion over the eyelid. And we know the most important site of the levator muscle is the center side. If there's too much adhesion and we cannot approach the levator at very precisely, maybe we cut some of the aponeurosis that will damage the levator system. And so we don't do this in the center as in performing a revision surgery. So I choose the temporal side to begin because the temporal side can have a little bit not that good levator function, and they won't affect the shape of the eye so much. So I did not remove any tissues now because we know she has a sunken eyelid. So it is best to preserve all the tissues. Now I'm doing the same over right eye. And I use the cotton swabs to poke the fat tissues because we need to preserve all the orbital fat. So we need to be careful not to damage it.
So, Dr. Lin, would you give a patient any medicine before surgery, like sedative or painkiller, for the patient before surgery?
If most of the time I don't give them any medication because neuroblock is effective for to remove all the pain, and if she's nervous, maybe some like Xanax, well, she will take before operation. But I prefer not to do that because I want the patient open the eyes as usual, and with just like usual when she is a very good spirit. So I mostly I do not give them some anti-anxiety medication.
How about the local injection? If the amount is as little as possible, because sometimes if you inject too much local can cause the ptosis. It's difficult to adjust the upper lid position during surgery. So how to prevent the local effect on the levator muscles?
Yes, I do not inject too much local at the wound near the wound. I only do the neural block, maybe use 0.5 milliliter.
Only 0.5 cc.
Yeah,
on one side.
0.5 for the neural block, and less than 1 milliliter for the wound. And I did it very shallow to prevent effect to elevator and OM. Okay, this is the first time she opened the eye, and as I'm doing the operation, this is not what I expected, because you can see the left eye is a little bit ptosis. So what I'm going to perform this surgery, I was expected that I do the perfect neuroblock as usual, but this shows that the left eye a little bit ptosis and the right eye a little bit lagophthalmos. That means there are two possibilities. One is that I inject too much local on the right O end of right eye, or I inject too much local on the levator of left eye. We can also have a symmetry result of if sometimes we are not have the precise neural block. There are tips that we can judge during surgery. The most effective way is that make patient open the eye frequently to see what is the influence of every step. Now I'm on count 8 millimeter now to have the incision for the lower lip, lower flap. Although I use the 8 millimeter for the incision now, but later after I close the wound for the lower lip, I use 7.5. Later I will expand that. Now I'm removing one stitches. There is an old stitches here. You can see there's a notch. There was one nylon here, so I need to remove it to have a smooth result. We cannot cut them directly because maybe there was tissue loss. So we have to remove only the nylon. when we reach the deeper tissue, maybe she will feel pain. And now we need to add the local, and this is better to spray on the tissue instead of injection for lowering the effect. I just removing another stitches. It is better to remove all the previous stitches, as we notice it is on the root of our surgery. In this case, I dissect the plant. I dissect the plant under the molar muscle and above the conjunctiva, because you can see she has a very thin eyelid, and we can expect that the OM is not that much, and the ability of closing eye is not that good. So, before operation, I asked the patient that actually she has the congenital ptosis as young. So, we can expect that the levator function might not be that good. So, if we resect lots of levator muscle, they will come to some lagophthalmus. So I will do the levator and molar resection at the same time, because molar muscle is more elastic. I do the same thing over the right eye, and I skip that. Now I will ask patient to open the eyes and mark 3 lines that indicate the nasal margin of the pupil and the central pupil and temporal side of the pupil. And now I'm going to find the molar muscle, the levator muscle and levator aponeurosis junction. And then in this case, I use 3 millimeter of the aponeurosis left, and I count 3 millimeter and mark it to be the site I'm going to resect. Now the stitches is out just on the site I mark, and it presents there will be 3 millimeter aponeurosis left in front of the aponeurosis and the muscle junction. We can see there's 2 lines. The upper line represents the junction of muscle and levator. The lower line represents the 3 millimeter aponeurosis left. This is 3 millimeter and mark it. So later I'll let my stitches suture on that. I always make to bite on levator, the tarsus, because I want the stitches very tight and secure. So I always make 2 bite on the tarsus. And the depth of the bite should be maybe 1/3 or 1/2 of the tarsus. And now we make one center levator advancement over both eyes, and it shows the 2 eyes are equally opened. So because we know all we do is the same over 2 eyes, and that becomes equally large. So maybe previously I found that there is not that good neural block result. Maybe it's wrong. That shows that the neural block might be just precise, because we know we do the same steps over 2 eyes, and the 2 eyes opened same levator function. So we can just relax and do check the eye, the symmetry without if the eye is symmetry, the result will be symmetry. So that is a good neural block. And it might be the mass effect, which leads the eye not symmetry as we open the eye at the first time. We know if the lid is thick and swelling, that will have the weight burden of the levator muscle. So maybe there is some mass effect, maybe too swelling, that make the left eye just a ptosis at the first time she opened the eye. Now I'm going to do the second and third levator advancement just below the marking line. Maybe she said she's pain, and I'm going to add some neural block here. Because it's a long surgery, please feel free if you have any questions. I'll answer you. most of the time, there was a question that I asked then how much elevator to resect. Most of the time, if this is old, the age over maybe 55, that we know that maybe the poor levator function might result from the levator aponeurosis dehiscence. Then maybe the muscle function is good, just dehiscent. So I will choose 4 to 5. And mostly that will have a good result. But always it depends. And if the patient is a congenital ptosis case, then I will check if the muscle is very thin and there is lots of fat infiltration or fibrosis on the levator, is a poor levator muscle, then I will use mostly lower than 1, maybe 0 or 1. And other cases, I will maybe just like 2 or 3 for the general levator advancement. And in this case, we can see that there is some adhesion as I dissect the levator plane. So maybe the ptosis mostly not only come from the poor muscle function, maybe come from the adhesion that make her cannot open the eye easily. So maybe so in this kind of case, I might choose maybe 3, but we always have the chance to change the plan as she open the eye and see how it affect. If not, it's not that good, we can just remove the stitch and do it again with a lower number. If you know that if in a revision case, you can see that there's a very severe adhesion, and patient did not say that she has ptosis before surgery. In this kind of revision case, I will choose 4 to 5 because the muscle is normal. Is not that problem, not from the muscle, it's from the adhesion. We know that there was a very severe sunken eyelid before surgery, and most of the time I will have the fat transplant. But I asked the patient, do you want to have an even eyelid or a little bit puffy eyelid? She said she only want a little bit improvement of the sunken. That is enough. She don't want to have the fat tissue suction and transplantation, so I did not do that for her. But sometimes I would do fat transplant for this kind of sunken patient. Now I'm remove a little bit OM. Okay, generally, I will cut the extension of levator aponeurosis because there is some ON before it. Okay, what I was do was that I excise a little bit skin because now there might not be some swelling effect, so I can judge the depth of the width of the lower flap clearly, and I found that the temporal side is too high for the left eye, so I cut some skin. Now because this is the old crease is lower than the new crease, so I need to remove the adhesion just below the crease. Now the number is 7.5 because I want to restore some pretarsal fullness for her. So I dissect at 8 millimeter, and I resuture it at 7.5 millimeter to restore the fullness. Now I'll do a step what I usually do that for the tau fixation, TAO fixation, tarsus and levator, aponeurosis and OM. And this is how I made a double eyelid. I do this for you to see, and I will cut it later because this case I'm doing a special approach because we know she has a very sunken eyelid, and I want to. There's the first reason that I want to keep all the muscles here to make the volume larger. The second is that she has the orbital fat very less, not enough. So maybe if I sunken over eyebrow more severe or keep the same sunken after surgery. So I want to keep the orbital fat just below the eyebrow, and I'm not going to pull it and fix it at the lower side. So how I make a good gliding zone? So I'm planning to keep all the extension of aponeurosis and fix it backward to the outer septum of orbital fat. So now you can see there is some extension of aponeurosis, and that is aponeurosis as part of OM. And so I make the tau fixation just like that to make sure the extension of levator aponeurosis is can be backward like this. I'm doing the tau fixation now. I will do 3 tau fixation, and I will close the skin temporarily to see the symmetry, and I will cut the suture I will resuture it later. So okay, now I'm doing the tau fixation for the nasal side, and I count maybe 6.3. Sorry, I forgot. I counted for the six only because sometimes maybe the nasal side fixation should be 1 millimeter lower than the central side. But in the sunken case, we know the nasal side should be very conservative, cannot be too high, because if the nasal side is too high, there will be some triangle eye. The shape is not smooth. So in some case, I will have a lower nasal side. I do the same over the right eye, and also keep the extension of aponeurosis like a roll, and that can lie backward for later suture. There's another question that I suggest hydrodissection before dissecting molar muscle from conjunctiva. This is a common way to do this step. This is very okay. I just don't do that, but this is a very good method. Lots of surgeons have hydrodissection before dissecting molar muscle. Now I'm going to close the skin temporarily to see the symmetry. we always make a patient when we ask patient to look forward, we need to make sure that there is no skin discomfort. So I will free her by remove all the OP site and make sure she's not discomfort over any place and sit with relax. We can see that it's not enough over temporal side of the left eye, and that's good on the right side, but it is weird that she always use the elevator raise the eyebrow of right eye. So maybe although the black eyeball is enough, but maybe she felt not the elevator function is not enough of the right eye of her own feeling, so she raised the right eyebrow. So even we see that the elevator function is good of right eye, I will take consider to her own feeling. So that later I will add a little bit elevator of the right eye. Now I'm going to so I sprayed the local and remove the elevator advancement now. And I resuture it a little bit temporal side for make the effect more temporally. There was a question that I use 0.5 millimeter lower landing incision site to increase pretarsal bulk. Yes. And if the patient have sunken eye, why do you release pre-aponeurosis to drop over? Because in my experience, if she has the severe, she has a problem of severe adhesion, I will drop the orbital fat, the preoperative orbital fat, and pour it over and fix it to the OM near the wound margin. That will have a good effect of prevent readhesion. But if she has sunken eye just beneath the eyebrow, it is best to have the good volume of the upper side orbital fat. The best way is inject some autologous fat into the septum, but this patient decide not to do that. So now I'm going to show some other ways instead. Because I know that less possibilities of readhesion, so I did not pull her fat out. Is that answer is enough for you? Now I'm to open the septum to remove a little bit orbital fat. And why I do that? Because it is okay to remove a little bit orbital fat over the temporal side, and I will use the fat to resume the sunken of the nasal side. And during operation, you can see there is more orbital fat over right eye than the left eye. So I will remove a little bit larger clumps of fat from the right eye to add the volume of the left eye of a nasal side. And I will remove a little bit smaller clumps from the temporal side of left eye and add it back to the nasal side of right eye. And I just close the, I just suture the extension of levator aponeurosis and suture it back to the outer septum. You can see that. And okay, now I'm going to do that. This is the outer septum of the orbital fat, and I connect it to the extension of aponeurosis. So in the inner side, there is a good gliding zone without fat. So that can prevent the readhesion and make a space to have a fat clump. So this is the way how I extend the septum without pulling the fat. Pulling the fat down. Yes, we need to judge the pre-operation picture before surgery, and in this case, she has a thin eye, so it's maybe that is good for her. Most of the time, I do not add the volume of pretarsal fullness. And if the patient hate her puffy eye, okay, sorry. Now I just add the fat clumps into the new septum. And close the final suture. If patient hate her own puffy eye, sometimes I will remove a little bit pretarsal tissue, but I seldom do it because it might affect the closing eye system and make a little bit lack of thalamus. So I love to preserve all the function from all the tissue. If she feels that she has a puffy eyelid, I will make a lower crease instead of removing the pretarsal muscle. I gave the neural block the amount of like 0.5, around the 0.5 over, and it will enough if the site is precise. Now I remove a little bit smaller fat clumps, and I will use it for the right eye. We always make a small incision to pull the fat out to preserve the septum. I just remove one nasal side towel fixation. I'm sorry, it's the center towel fixation. Maybe for the symmetry. There's a question that at which level you would attach the outer septum to the extension of levator a bit higher than your levator tarsus attachment. Yeah. Maybe 2 millimeter higher, but it depends on the length of levator, because if I suture the extension of aponeurosis to the septum and the lower side is OM only, the inner side of OM still is a rough surface. It's not okay for the gliding. So it depends on how much levator left. If there is, sometimes there is 2 to 3 millimeter levator, and then I use it to be everted to suture it onto the septum. We should make sure that what we bite is the aponeurosis, because only the aponeurosis have the smooth surface for the gliding. And there's another question that how far do you extend temporally? Chinese like a flare look. I found temporally really hard to suture. Sorry, I a little bit don't understand this question. If the patient has very fatty medial pretarsal tissue, do you remove it? Yes, I will remove the fat tissue on medial tarsus, but there might be bleeding and we have to be careful. The advantage of removing the medial tarsal fat is you can make your crease secure over the medial side, because fat will make the crease shallow or not secure over medial side. And it's sometimes the change of the elderly, so it's better remove some of them to resume the young look. Also, I need to say, I need to explain the suture the stitches I use. That I use 60 PDS for the towel fixation, and I use 70 Vicryl for suture the extension of aponeurosis to the outer septum. I use the 70 Vicryl. There's another question. There's a question that the temporal skin crease sometimes stop prematurely. How do you suture the temporal crease so that it extends laterally about a few millimeters? I will fix it to the end later. I always fix the towel fixation. I always do that for 6 suture, and the most temporal side I will not do it very deep. I'm sorry, I am not going to do it very high, and of course it should be deep into the tarsus. The tissue near tarsus, and of course there's no levator muscle, but you can still suture some extension of it. Oh, that's another question. On the attachment of levator onto tarsus, do you left a small stump of levator under ocularis? how much you left without creating a bulky stump. It depends the height of crease I want to make, because I always do the elevator advancement near maybe 1 millimeter down from the upper tarsus margin. So if I now I'm going to put the orbital fat clump into the right eye. Keep the question that back to the question that so if I'm going to make a very low crease, I have to left more stump of levator. But if I may make a higher crease, that I need to excise more extension of aponeurosis to make the pretarsal not bulky. I will pave the levator and count how much I need to excise. It depends on cases. So now I'm going to do another 2 tau fixation for the temporal side and 1 tau fixation for the nasal side. There's another question that I want to know: after resect levator, you must suture it with skin or not? I don't suture it with skin. I will suture it to the OM just beneath the skin by the tau fixation, TAO fixation. Can you mention the gliding plan again? You said raw edge of ocularis is not good weight for side gliding. Oh. This is the levator and the muscle and the aponeurosis, and we fix here, and this is the extension of aponeurosis, and this is the OM. We don't use the OM to fix to the upper septum because the inside of the OM is rough. It cannot provide the smooth gliding zone, so I will cut them and remain that aponeurosis extension. This is the side I do the tau fixation, and this is the extension, and this is the cut end, and I will suture it to the upper septum like that, and there provide a good gliding zone. I insert a fat clump just into that gliding zone beneath the new upper septum and above the levator. if in some case we have the autologous fat transplantation, I will inject fat into that space as well. I love to inject fat into the septum because it will be very natural. If we inject that to the OM and subcutaneous layer, it is good, but not that nature. But it is very effective to improve the sunken eyelid as well. I will close the skin with some interrupt suture with OM combined under the wound that can prevent sunken scar. And later I will do interlocking suture for other side to close the wound. Yeah, I just there's another question that how I inject the fat into septum. Yes, I always do that with an open method. If it's I inject the fat without open the wound, I just inject them into the soft tissue layer blindly. Of course, we need to spray the fat evenly if we don't open the wound. I suggest inject into the septum only as we open the wound by an incisional method. I feel a little bit thick from the nasal side of left eye, so I will resuture it later. It is too wide here, so I will make a narrow one. Yes, I centrifuge the fat. What I mean autologous fat, I always do the sorry, I should say that micro autologous fat. As I mentioned that fat transplantation, I mean micro autologous fat. I always do it with a MAFT gun, MAFT, MAFT gun. It's a good way to do this precisely. Sometimes I use 3000 for 3 minutes. For the question. I close the wound with skin, OM skin. I only close the wound and not make any double eyelid by that method, by this step. Here's a question. You did not cut the skin. How did you make it smaller? You mean the lower crease? Actually, I did resize a little bit skin at the beginning of the surgery, and we know that after the the sunken eyelid will make the crease larger, and if the eyelid become puffy, although there is a same crease, it will look smaller. And most reason for the crease she did not like before surgery, that because of it is multiple crease. She did not ask me to lower the crease. Yes, there's this question I saw you dissect quite a lot into pretarsal plan. Isn't that can cause a lot of edema post-op, as can impair lymphatic flow, of course. So I seldom do this, just because of because less surgery, the suture is lower than this time. The crease is lower than this time. So if we want to higher the crease, we need to release all the adhesion of that surgery, from that surgery. I make the crease by tau fixation, TAO fixation. What is tau? That means tarsus, aponeurosis, and OM. So I only close the skin. And I count 705 for the new crease. Now I'm doing interlocking continuous suture, and that's the end of the surgery. I will do it for the right eye, but I'm not going to show that repeated method. This is a question that said that it formed quite well, but did not see you suture deep OM to septum. I did that as I do the tau fixation over temporal side. The total number of the tau fixation is 3 in the middle, 2 for the temporal side, and 1 for the nasal side. the tau orbicularis is not the inferior. The OM I got is the skin, but the skin just beneath the OM just beneath the skin. This is for the OM of the tau. And this is the post-operative picture. I did a surgery on October 5th, and this is the picture right after surgery. That's how I see that, and I let her go home. And she come back 3 days ago, and this is the picture of that day. Okay, thank you very much.
Thank you, Dr. Shen Junling. Congratulations, you achieved an amazing result. Only 1 week after surgery, we can see this female. She got the lovely eyes, upper lids, and without much swollen. I believe she must be very satisfied with this early result. Thank you, congratulations. 谢谢。那谢谢林医师。应该 any question from audience? So I didn't see any comment or question at the WT website. So maybe we finish this section. Thank you, Dr. Lin, for your wonderful demonstration, and showed us many detailed procedure in the upper eyelid surgery. Thank you.
Thank you, Dr. Gao and Dr. Ling. And now we will have a 30 minutes break. So be on time later and see you. Thank you.